fortunate. I'm very happy to be here.
All right, we are live, and this is Senate Health and Welfare. We're back. We're picking up a bill that was introduced, S-263, an act relating to expanding Vermont's healthcare workforce through graduates of international med schools. And so obviously workforce has been an issue for us right along. And this is a bill that Senator Harrison has introduced, and welcome to the committee. Have you been here before?
Thank you, Madam Chair. No, I have not.
All right,
It's my
so
first time.
great. Why don't you introduce yourself for the record, and we'll listen to your testimony.
Thank you. For the record, I'm Senator Wendy Harrison. I represent the Windham District, and I'm here today to introduce S-263. The intent of the bill is to identify opportunities to utilize graduates of international medical schools already living here in our state to improve Vermonters' access to primary health care, as well as the lives of those graduates and their families. It proposes two actions. One is the beginning of a long-term solution. The other is to make short-term progress. I want to acknowledge and thank the NAACP of Windham County's Health Justice Subcommittee for contacting me regarding credentialing challenges for international medical school graduates and educating me on this complicated structure. Credentialing is just one of the barriers faced by new Vermonters who want to use their skills and experience to provide medical services in their new home. The standard residency requirement is a bottleneck in the system that produces doctors. It's expensive and has very limited capacity. The Health Justice Subcommittee was interested in Vermont considering a new law in Tennessee that provides an alternative to the standard residency requirement. I have also learned from the Board of Medical Practice the importance of the residency to patient safety and outcomes. And after my conversations with the executive director, I structured the bill as a working group in that section rather than proposing that we adopt the Tennessee law. I'd like to share two observations that I found notable in an abstract on PubMed Central. First one, a study exploring the acculturation of non-US international medical school graduates in a pediatric residency program found that overall, foreign-trained residents deemed the US life and culture more complex to adjust to than the United States healthcare system. Such difficulties comprised housing, daycare, grocery shopping, common sports, and the American school system. The other one, international medical school graduates from Asian and Hispanic origins share strong family bonds. In coming to a society with situations that lack a family connection, such as hospitalized geriatric patients receiving no visits and adult children placing parents in remote nursing homes, is alarming to them. So back to the bill. The long-term solution would begin with a working study convened by the Board of Medical Practice to develop proposals to utilize the expertise of international medical school graduates to increase Vermont's healthcare workforce. The membership of the working group is suggested in the bill, and you'll go over this with Ledge Council. The working group would review the Tennessee law and consider other models and opportunities that would be appropriate for Vermont, reporting back to this committee, your counterpart in the other body, and to both government operations committees by next January. The short-term initiative is to help international medical school graduates pay for books, study materials, and software that they need to become licensed in Vermont. The bill proposes a one-time appropriation of $50,000. It would be administered by the health department with the help of the area health education centers. This bill seeks to improve access to medical care by increasing the medical workforce and the diversity in that workforce through finding a way for talented and educated medical professionals to practice in Vermont. Thank you for having me. I'm happy to answer any questions you may have, and I hope that you will support this bill.
Thank you. It's a lot of work to put that all together.
I had a lot of help.
Yeah.
I learned a lot from
That's good.
very, well,
Good.
folks in my area, and I've sent a witness list, so that
Oh,
You
good.
can hear
Did you
from-
send it to Kiki?
I did.
Yeah,
yes.
good. Oh, that's helpful. Okay. And I'm sure others will show up.
So Senator Harrison, there's a pretty robust stream of medical folks who are coming into the US. And the process takes years. I understand that. I'm wondering what this changes. I mean, if that process, although laborious, is working, what are we trying to affect?
What this would do, what the Tennessee law looked at was finding an alternative to residency, because the residency requirements are the bottleneck.
So
And
is this residency just for doctors or?
this is just
nurses?
for doctors, because doctors are the ones who are regulated by the medical board, medical board of medical practice. In my other hat on the Economic Development Committee, we did look at and expand compacts with other states for nurses, and that's under the Office of Professional Regulation. And we did recommend that the Office of Professional Regulation be part of the workforce or work group. But what the thing that the Tennessee law does is it allows people who are international medical school graduates who have practice to spend at least 2 years in a hospital in Tennessee that has a residency program, but it doesn't require them to be part of a residency program. And one of what I learned, and you all know better than I do, I'm sure, is just the value of the residency program, and making sure that individuals have the capability and the experience and to keep patients safe.
Go ahead.
So I'm kind of confusing maybe residency as in like to qualify for some state education support.
Oh,
You have to be a resident of the state for. a particular
Oh,
amount
I'm
of time.
sorry.
And then you also, I think maybe in your example, you're talking about doctor's residency as part of the process of qualification.
Yes, I should have made that clear. Yes, I'm talking about the medical residency that's required after medical school for everyone, not just international medical school graduates. All medical school graduates must go through a residency program. Some are 2 years, some are 3 years. They even go longer, 5 years. So that's the bottleneck. And I'm sorry, I should have made that clear.
And not all hospitals have resident.
Right, I think
Yeah,
UVM is the
we'll have to
only
pick
one
out all of that.
in
Yeah.
Vermont that has a residency program. And just if I could stray a little, I mean,
Okay,
if we could increase the amount of residency spots in Vermont, I think that would help. But I don't have a proposal to do that.
that's a big,
So who provides the supervision and are there gonna be an evaluation process after the residency? Is it gonna be the medical school or the hospital?
That is what the working group would determine.
Okay.
And they would be looking at the benefits of having more doctors versus the, making sure that those doctors are very well qualified.
and oversight, yeah. Okay, other questions for, go ahead.
Just a comment. So 100% support study. I get that. If another state is looking at it and it makes sense, okay, we should follow and take a look as well. We obviously have a shortage of doctors and other medical professionals in the state. And I'll stop there. I think it's a great idea. I like the fact that you're advocating a study prior to introducing the solution. We often kind of go at it from an opposite direction, where we propose a solution and we also put a study in it. So I commend you for that.
Thank you. And you'll hear from medical school graduates who are in that space and can tell you much more about the details than I can.
Maybe we could do a committee trip to Tennessee,
Oh,
go to Nashville.
yeah, Nashville,
Or the hospital
Memphis.
down there.
Memphis is,
Yes.
yeah, okay. We're always looking for great field trips.
That's true.
All right, so thank you, Senator Harrison. That's been
Thank you very much.
a new place for us. We've got a lot of new places we're going to this session. No guarantees, but we will go through the bill with Ledge Council and maybe we'll get somewhere.
And I'm
That
staying on.
you do understand you have an appropriation in the bill, and that
Yes.
for us is down home.
I understand.
Yeah,
Thank
so
you.
we'll be talking about that. So Jen, thank you for being here again, and why don't we just walk through the bill? I know Senator Harrison's given us a very good look, but we need to see the bill.
Sure. Again, Jennifer Carby, Legislative Counsel. I will put the, make sure I can get the document up this time. All right. All right. Can you see S263 now?
Yes.
Oh, good. All right. So as you heard, this is an act relating to expanding Vermont's healthcare workforce through graduates of international medical schools. And it starts with a working group, directs the Board of Medical Practice to convene a working group to develop proposals for harnessing the expertise of international medical school graduates to increase Vermont's healthcare workforce. Have the working group include representatives of Vermont hospitals, including University of Vermont Medical Center, of primary care and mental health providers, of the area health education centers, of international medical school graduates, the Office of Professional Regulation, Department of Health, and other interested stakeholders. Directs the working group to examine implementation of Tennessee's law, which allows the issuance of temporary medical licenses to international medical students under certain circumstances. Also would have the working group consider other models and opportunities to create an expedited Vermont licensure process for trained healthcare professionals from other countries to increase Vermonters' access to healthcare services, including primary care services, while prioritizing and protecting patient safety. And it would have the working group, the board reporting the working group's findings, recommendations, and proposals for legislative action by next January 15th to this committee and others. Then, as you mentioned, Section 2 has an appropriation. It would appropriate $50,000 in fiscal year 2025 from the general fund to the health department. And this would be to reimburse international medical school graduates for all or a portion of the cost of their books, study materials, and software that they need to become licensed to practice medicine in Vermont. We would have the Department of Health administering the funds in consultation with AHEC, the Area Health Education Centers program at the UVM College of Medicine. And funds would be awarded to eligible international medical school graduates on a first come, first served basis until the funds are depleted. The act would take effect on July 1st.
Okay, yeah, so there's a lot embedded in that appropriation section. Because first of all, the eligibility, which type of physician, is it all primary care? Senator Harrison, you mentioned primary care in your introduction. Was the intent to focus on primary care?
Yes.
Okay, so that would be kind of the lens, the initial lens, and then there's first come, first serve. And I know AHEC has a program for distribution of funds. Department of Health would have something to say. There's a lot here. Okay, go ahead.
Thanks, Madam Chair. Jen, I am looking at the Office of Professional Regulations foreign credentialing stuff. We passed a bill, I think, 4 years ago, maybe 2019, 2020, that updated or created a sort of provisions related to credentialing of foreign and recent immigrants. And I'm just looking at the table as to, it includes some physicians and other medical, but not, it doesn't look like it includes all physicians, but I'm just wondering I wonder if we already sort of did this.
I'm just looking at this. I'm not sure if there's something similar for the Board of Medical Practice. So it may exist for doctors of osteopathy to the extent there are training programs for osteopaths in other countries. I don't believe we have something similar for medical doctors.
Yeah, it does look like it's osteopathy and nurses and naturopathic.
That's because that's who
OPR.
they regulate, right?
Yeah, OPR regulates those professions, and then Board of Medical Practice regulates,
No,
and-
I know
yeah.
that, but I just wondered if when we, I guess is that, can we just expand what we did or build on what we did, or did, I don't, I just know that we did a lot of work on this issue a few years ago and, wouldn't wanna go through all
And I
of
think
it.
that's the value of having OPR in the room when the discussion happens with about the residency programs and about what's happening in Tennessee. So there might be some benefit that comes from that work that was done. And Senator Harrison.
No,
I'll let you
exactly,
comment.
Madam Chair, that's what I was going to say, that's why OPR is, part of the working group.
Right.
Yes.
It'll be helpful to have that information available when, Board of Medical Practice pulls folks together. And I think AHEC might have been involved in that, I'm not sure, in the past. All right, so this is an interesting, opportunity, I think. It's a working group, but it's a working group with a plan to look at, Tennessee. My question of the committee is, do you want to, we can take some testimony on this. It doesn't look like a heavy lift. Not gonna say the other word, it doesn't look like a heavy lift. Yeah, so we'll put it up on the agenda, and then, Senator Harrison's provided some folks for testimony. There might be others interested who'd like to come in, and I know some in the room now might be interested in that. As a stakeholder, then the big question is with regard to the materials and the $50,000. We don't want that to be the barrier that gets in the way. Having said that, it might be something that helps. My question actually is that the cart before the horse. Does that get folded into the working group as what resources are needed going forward? Because as it's written here, we've got money in to help these folks become practitioners, and yet we're studying how to make that happen. So,
It's a wording.
yeah.
Yeah, so I don't have a lot of experience in this environment,
Yeah.
but, if money kills this initiative, then we've done ourselves a disservice.
Yeah.
I think that the study committee, the study group, I think is, 100%, a great initiative. And I would hate to see the money folks kind of pull the plug in the bill and say, sorry.
That's possible.
It's,
Yeah, I know it's possible. Did you want to comment?
If you want me to,
Yeah,
yes.
you're here, so please do.
First, if the money is if the money in the second part would, cause the entire bill to be not considered, then yes, strip it. I recommend and request that you talk to the folks who are, the IMG graduates who are here, because the way they explained it to me, there are certain tests that you need to take anyway, whether or not you're, in order to get to residency, so they would likely be required. And the books and the software that you need to take those tests, they're very expensive. So I think even if there was a $20,000 allocation, I think any funding would be helpful to them, but they can describe it better than I can, and they are on the witness list.
Okay, we'll hear testimony, and this is a question that we'll have to answer as we hear the testimony. Go ahead.
I'm definitely interested in the testimony. I'm just concerned also that we already don't provide enough support for American medical students who are coming to Vermont to get trained, and we are, compared to what other states are doing, we are way, way behind. And I would be concerned about
targeting,
diverting resources and targeting a different group of medical students, before we even are taking care of, Vermonters who want to go to medical school, in Vermont. So,
a residency.
and maybe
This is
some of these
like-
people
yeah.
are probably already in Vermont, so I don't want to make that distinction, but, you know, I just want to make sure that we're looking at the big picture about how we're supporting medical students, because we're already like way
Totally
behind the eight
agree
ball
with
on
you.
this.
Totally agree. Exact thought that went through my head when I first looked at this. So so this is we'll put it all on the table, and we'll have to hear the testimony and then sort out what our thinking is going forward. Good. But I'm not hearing we want to stop it dead in its tracks at this point. All right, well, that's good. Thank you.
Thank you.
Very, very
Very much.
helpful. And thanks for providing some witnesses for us.
pleasure.
I know we'll hear from others. All right, so we have Nolan coming in on S-109 at 11:30, and we're 6 minutes ahead. So we can go ahead, Rebecca, or we can just take a break. It's up to you. I'll leave with you. Committee, do you want to go ahead? Yes, all right, let's do it.
Oh,
Rebecca. And you're here now on
I'm
S-109.
here for S-109, Rebecca Gopans, Blue Cross Blue Shield of Vermont. And I heard your testimony, your conversation yesterday, and Senator Weeks had a couple of questions. And I can, Senator, I can send you the testimony I gave you if that would be helpful. And I could just make 4 points that, if that's okay, if I may. I really appreciate, OPR has a phenomenal way of stakeholder engagement. So I would fully support them doing the Sunrise process. Lauren is phenomenal. Both Laurens are phenomenal. They are really good at making sure that everyone is heard, all stakeholders are brought into the process. So I think that's a great idea. The competencies around certification, it's really complicated, and it's why during our pilot we chose to step away from the certification process and let individual patients choose the person they felt most confident about. The doula advisory board is a great idea as a way to navigate a really complex challenge. Trying to list different competencies in statute. It's interesting, you heard from Maria Rossi from Washington County Mental Health. One of the biggest reasons that we decided to step away from the competency question was the point that Maria made about the health equity, or the equity question for doulas, or people that have, where English is their second language. If they're not very good writers, a lot of those current competencies are really difficult for different people who learn differently or who write differently or speak differently. So tasking that to a doula advisory board is a great way to go. Something that is really extremely important that I didn't mention, that another witness did, when we were building our pilot, we looked to the California doula pilot, which was, it was groundbreaking when they did it. One of the greatest findings that came out of that was that community-based services, the outcomes are better for people who use a doula from a community-based service rather than a hospital-based employee doula. And it has to do with when someone feels distrustful of a medical establishment, having another employee of that establishment in their, as their supposedly trusted person, there can be some challenges with that. The data shows that the outcomes are better for severe maternal morbidities when they have someone that they are able to choose that comes with them into the hospital or into the birthing center. So it's just really critical to consider community-based services as a place to look for the doulas. The fourth point
Can I
is,
ask you a question here? As you're going through your pilot, will it make a difference to your reimbursement of doulas as to whether or not they're hospital or community-based?
No.
Okay.
so we.
It's the patient that.
It's the patient, yes. So we go through, our pilot is through the Better Beginnings program. And there's a lot of creativity in Better Beginnings around, how to get people the services they need. We have a carpool. Thinking a lot about carpool. A car seat reimbursement.
Car seats.
Yeah, and so the person, the new parent can buy a car seat and we just pay them a dollar figure, as a reimbursement for the car seat. So they just send in their receipt and we pay them, a portion of it. So we are doing the doula, as a similar process. The person they choose their own doula, they hire them independently. They submit the invoice and we pay up to $1,000. Which goes to the DIVA question about rate setting. I think putting rates in statute is complicated. DIVA has a really complex process about how to set rates, and we would support that being an independent, external, their process is, it works for a lot of things, so trusting them to do that would be great.
So community-based versus hospital-based, are they gonna, it would be beneficial, I think, to have a relationship with the hospital. I mean, a lot of your midwives have,
Or certification,
but it's,
registration, yeah, whatever comes out for you.
So like, for example, Washington County Mental Health has one of the longest standing doula projects, it's called the Doula Project in the state of Vermont. They have very good relationships with their local hospital, Central Vermont Medical Center. I think they also go to, they may travel as well, but doulas have relationships, as that's what they do and the jobs that, they have relationships with the hospitals and the midwives. But I think trusting the patient is really important to be able to make the decision of the person that works best for them. And if you have an advisory board to think about the certification process, it would kind of solve it would feed two birds with one stone, one seed.
Oh, I like that.
We're trying to move away.
Yes, from killing birds to
Yeah.
feeding birds.
That's right.
I
I like that.
And that's it. That's all I have to say.
That's a lot. And will you get us that?
Sure. You want me to write this down? Yeah, be happy
I mean,
to.
there's a lot of
Just
good
take a picture
information.
of it.
And it's helpful in our, we've gotten to a place where we've made decisions and we're trying to look at language so we can pass it out, but it will be very helpful for whomever is the reporter of the bill.
Sure.
We haven't decided yet, but we're getting there. Okay, Senator
So
Weeks.
this is a question, so sitting here listening to your testimony this morning, makes me remember your testimony previously. So and help me out if I don't paraphrase this correctly, but you currently have a program pilot, 30 seats, 30 positions.
Yeah.
But you're evaluating whether you want to continue the program. Is that correct?
That is.
Okay, all right. So I apologize my question was, well, what's the commercial side? What's their perspective of doulas? How's it affecting insurance coverage? How's it, if you're embracing it, if the private insurers are or are not embracing it, to me, that affects whether we dedicate Treasury to Medicaid to do the same thing. So that was the nature of the question. So I apologize. At the moment, a day or two ago, when we were last talking about this, I did not remember about your 30 seats in your pilot program. So that was the nature.
It is interesting to see, there's been a real shift nationally in a focus on health equity, maternal health especially. And as the data is more just shockingly clear, we need to step in and do more to support people who are going through something that can be potentially incredibly dangerous. So this is we're trying to be thoughtful in how we approach it and to make sure that we are supporting our members in the right way. And it's
probably in the long run and maybe even the short run, gonna save them money. Because if it prevents more expensive interventions that would then have to be paid for by insurance, like a C-section or an emergency birth or something, it's cost effective too. So like adding it to all the wonderful equity and care reasons is saves money.
Yes, I present it as the heart and the pocketbook.
Yes, exactly.
And it
We like that.
Solves both those.
We're all about that in here. Senator Weeks, go ahead.
Yeah, no, I get that. So for a commercial insurance company or any commercial entity to make a decision, typically they're looking for some type of return on investment.
Yeah.
Okay, so, but my hesitation about supporting the bill now is that if the commercial insurance companies aren't embracing this concept, how it becomes an entitlement before the commercial side offers it to, you know, the other, whatever, 60–70% of the population. That, you know, why should it be an entitlement in Medicaid before it's offered to the rest of the population? So that's my only hesitation. So I'm most keen on the results of your pilot before actually supporting the bill. Although I get the concept, I think we should learn from your experience before we commit to creating another entitlement. Because of the nature, the high cost of healthcare, as we've seen, and the effect on the education.
Well,
And
you know,
can I just respond
Go
to that?
back
Yeah, I
to
was just gonna say,
Senator Harris.
so
Oh, go ahead.
it will
Senator
save
Harris.
Medicaid money too.
Yeah.
And a lot of the individuals who are having babies, actually probably Medicaid is the not probably, I think Medicaid is the largest
Well, on the
insurer
list.
of people who are having babies in Vermont. It is the largest insurer in Vermont, period, in terms of the numbers of people who are covered by Medicaid. And so I think that the whole concept of saving money, it will save the state and the federal government money too by covering doulas because they'll prevent higher cost births. And a lot of the people who are having babies who are on Medicaid are the highest risk. I'm gonna venture to guess, I haven't looked, that they're the highest risk people who are more likely to have complications.
So what I'm going to do, this is a robust, really good discussion, and we need to hear from Nolan on a fiscal note. And then this is where we want to get when we have the final language sitting on the table. But Blue Cross and Blue Shield is supportive.
We are agnostic on the bill.
Of course, Medicaid.
I think it's a question between, Medicaid and the legislature.
Okay. And if we added private insurers in there, what would happen?
So it's not something we cover now. And so it would be a question of the essential health benefits, like a defrayal, which we can do.
So we're gonna hear from Nolan, that's why we have here.
Can you say that again, your last sentence?
Okay, Nolan will explain
Yeah,
that.
Nolan's coming up, that's his job.
So I'm impressed you were paying attention.
Hold on.
That's not the bill.
No, it is not the bill. No, it's just information that we've gleaned. What's that?
For the record, Noel Mangle, the Joint Fiscal Office. What Rebecca was talking about is when the Affordable Care Act, and if you want to know more about this, I will defer to Legislative Council to explain it. But the basic concept is,
Not there.
okay, basic concept is that there's an essential health benefit package that's been defined.
Mhm.
And to the extent that we put any more mandates in law that don't fit into those buckets of what's there, the state has to pick up the additional premium costs for people. So it becomes a state cost. If you want to know more about it, I would invite Jen in to explain it more in detail. I wasn't going to start with this. Well, first I'm going to say there is not a fiscal note yet because you haven't made key decisions.
Right.
When you make a decision about what the rate will be, then I can start putting it up. But I have the bones of the fiscal note, and I'll tell you what will be in it. I wasn't going to start with savings, but I'm going to start with savings. And that the essential, I think you've heard people talking about it, and I've been looking at different research and conglomerations of people putting all the research together. And, you know, the evidence suggests that, yes, there would be, from the reduction of cesarean sections, folks with low birth weight and premature labors, decrease in epidermal use, increased rates of breastfeeding, et cetera, there will be, in theory, there would be savings in the system. The research and the studies support that it would help reduce costs. That said, I cannot book those costs. So when we think about what the costs of the program will be, I can't be like, oh, well, the cost is going to cost X, but hey, we're going to get all these savings, I can't offset them in this year. It would be something that'd be longitudinal and built into the base. What you could do is you could say, ask EVA, if you would pass this bill, to provide a study in 3 years, 4 years, showing, you know, the potential reductions.
Return on investment.
Yeah, you know, ways to measure return on investment. That would be the recommendation if you want to measure savings, but we can't book those savings. And there's multiple reasons why. Well, one, we don't know. But two, and this feeds into the second piece, the actual cost will depend on the utilization of this program. So one of the things I looked at was a study that was done in 2023, and it looked at 5 states that have done Medicaid. I think there's about 13 states now that have done it, including, plus the District of Columbia, that have done Medicaid doula coverage. And the study looked at 5 of them, and they found that despite the high demand for it, there was low utilization of the program. And the reason was lack of awareness, and also workforce issues. You know, the other piece of it that also contributed to with low reimbursement rates, the ease of enrolling as a Medicaid provider. These folks are not currently enrolled in Medicaid providers. Billing codes that don't reflect scope of work. So a lot of times these folks aren't billing Medicaid. They're a little bit more non-traditional, so they don't have the billing structures that a lot of our providers do. That other administrative burdens of getting paid. So those are kind of things that have affected the utilization of doulas, looking at in some states where there's lower rates, saying, well, reimbursement rate's kind of low, is it really worth me doing this? So you've heard from other folks, including Matt, like what he thinks other states are doing and what the reimbursements will be. I cannot tell you what to do. I will just tell you that has been lower reimbursement rates has been tagged as one of the reasons that the utilization has been relatively low in those states. So as such, when I'm looking at my costs in the early years, I'm going to assume that the take-up rate in the first and second years are going to be on the low side. So you saw it from DEVA, they presented a chart, and the chart ranged from, you know, $180,000 to 1.8 million.
Right.
I can tell you it will, and that's you know, that's them showing 100, you know.
Right.
And what they've done was they said, okay, there's 2,100 births of Medicaid, I think in 2022, I have the number in my fiscal note here, 2137, and that was from 21 to 22. Medicaid paid for 2,137 births. And so they took that number, they multiplied it by the utilization rate, and that's what you're getting. So there's not gonna be 100%. At 10%, the utilization at $850, which is what's in the bill, you know, they were saying that it would be $180,000. Now, of course, there'd also be Medicaid match. So we were assuming that it would get a Medicaid match.
Medicaid
So
match.
so it would be less. And that would depend on what the federal match rate, and that would depend on what the federal match rate is in the years that it gets implemented. So when I come in with a fiscal note, I'm going to assume, and I'm going to assume a year 1 low and a year 1 high, and it's going to be between 3 and 6%. So it's going to be very low. If it were 3 at 8, just to give you a sense of what the costs are, at $850 reimbursement rate as a max, at 3%, the total cost would be $55,000, and the state share would be about $23,000. If you go up, I ran some scenarios. If you went up to, let's say, 1,700, it would be $108,000 gross, and then then about $45,000, $46,000 net, right? Match. If you went to, I just ran numbers, I'm not suggesting anything. If you went to $2,000 at 3% to 6%, it would be $128,000. At 6%, it would be $260,000 roughly. That's gross. So I'm just trying to give you a sense of the total cost, and that would depend. And again, what drives it is utilization. So I would give you a range, and then what the rate is. So those are going to be decision points that the committee has to make. And then down the road, if you're successful, it's gonna cost more down the road, but then you could look at the savings farther down the road and say, okay, how many people would have had these complications, et cetera. So those are some of the initial, that's the thinking of what my fiscal note will say. Again, you'll have to decide what the rate needs to be. The other piece that I want to talk about, and I believe you heard from OPR and from DEVA.
Can I ask?
Oh, sure.
So what if we actually don't put the rate in the bill and we say that, DEVA is
Floor,
gonna
put a floor in.
figure it out based on their rate setting process?
If you didn't put a rate in the bill, I would probably come up with an estimate of what it might be and give a range. Like if they do the rate, this is a rate, and they might do that as a rate, and I might talk to them and just get a sense of like, what do you think it might be? And they probably will say, well, we can't tell you what it will be yet because we have to go through our process, which is completely legitimate. But I might come up with a range of what the rate might be. And then I would also use the percentage of what I think the uptake would be, and it would be a range. And then appropriations would have to decide how to, where to land in that fiscal year. So, but they have a range on it.
Or a floor.
You could do a
Yeah,
floor.
a floor,
and that was,
a range, I mean, we've had talked about that, so.
yeah,
But
the
we've
floor.
heard not to put the rates in.
Yeah, and we generally don't. I mean, I think, I won't tell you that. So let's just say that DEVA has a process for how they do things, and it's probably good to be consistent with it. I'll leave it at that. The other thing, well,
Senator
Senator,
Williams.
So I just, a question for Rebecca, and Blue Cross doesn't cover dual services, right?
So we have a pilot.
They do.
Yeah. 30
Yes.
people.
We have 30 people in our pilot, and we're looking at, I'm very excited about looking at the data that the pilot, Vermont-specific data that the pilot should give us.
Okay.
So we're about halfway through it at the moment.
Good.
the other thing I want to flag is other places where there will be some potential fiscal costs are in the admin. You heard from OPR, and they talked about their sunrise report for study that they have to do. They're not funded for that. So, and we had, as you know, we've been doing lots of compacts, and so their budget is already stressed. And so you might consider some amount of general fund to help them get up and running while they determine, while they do the determination of that, and then also figure out what their rate, what their fee schedule should be to help. Because obviously there's a regulatory piece in that, and they have to figure out what that fee should be.
They have not come to us with a request for a specific amount. I have heard that there are concerns about financing their work.
They haven't come to you, but I have talked to them, and I'm also seeing the bigger picture of all the things we've been putting on OPR, and I'm very mindful of the level of stress we're putting on them, the things we're asking of them, and we just need to be cognizant of workloads and financial capacity to do the things that we've been asking them to do.
Yeah.
So I will leave it at that.
So, well, and we can't get a fiscal note firm until we have a bill that we've decided on. We understand that, so.
And my fiscal note will do one of two things. It will either flag it and say this is a concern that needs further, that may need appropriate, or I will have a number from them saying, according to OPR, this is how much they think they would need to do it. But I'm just letting you know that my fiscal note will address that in some form or another.
Terrific. I mean, that is very helpful. Thank you.
And then there's also some AHS stuff. You know, like they have to do manpower around, you know, state plan amendments and rules and setting up reimbursement schedules. I don't know if they need any money to do that stuff, but they may. I just flag it as a potential concern. I think that's all I have on this for now.
So when we go through the bill next time, it'll be with an intent of finalizing the language as much as possible.
Mm-hmm.
And so it would be helpful to have you here and of course sort through. Yeah, okay.
Yeah.
Good. Terrific. Thank you.
Yeah, you're welcome.
It's been very helpful. All right, and today we have folks from the developmental disabilities area talking about the housing initiative. And Jen Townley is here, and who else?
This is my son Bennett.
Oh, Ben, terrific. Thanks for being here. I know you represent a larger group, but we have folks in the room here today with the developmental disabilities. Are you all representing housing initiatives,
Yes.
or is it also
Housing.
developmental?
Yeah.
This is great, and it goes back to a bill we passed, I think, in 2022.
That's correct.
Yeah,
And thank you so-
history here.
Thank you so much for your support for that. We as
Yeah.
DDH are appreciative of that, and I've been in DDHI as part of its inception. We're a group of over 100 parents across the state that are advocating for services.
Can you do something for me?
Sure.
Can you please introduce
Oh, I'm
yourself
sorry, sure.
and your son? And we're gonna introduce ourselves to you first.
Okay,
Okay.
I'm sorry.
No, it's great. No, it's terrific. It's good
So
to
I'm-
have you go ahead.
Yeah, I'm Jennifer Townley, and I am the parent.
My name is Bennett Townley and I'm the patient or whatever.
No,
it's
you're the,
called.
you're here to advocate.
Okay, I'm the advocate. Advocate.
Good. We like that you're here as an advocate. Terrific.
Yeah.
So we'll start here with Senator.
Hi, Senator Hulick, Barack Hulick. I'm in the Chittenden Central District. Nice to meet you.
Good morning, Dave Weeks from Rutland County.
Thank you. Ginny Lyons, Chittenden Southeast District.
Terry Williams, representing Rutland County.
Thank you.
Good morning, I'm Ruth Hardy, I represent the Addison District.
Nice to meet you.
There you go.
Okay, I apologize.
No, don't apologize. It's great. Okay.
But you forgot the people in the back.
Well, we should have them introduce themselves. Let's do that right now. Good idea. Thank you, Ben.
I'll start. I'm Kristen Chandler. I'm with Team Two. I'm gonna be sitting in that chair in a little while.
Hi, Bennett. We met outside. I'm Lindsay Owen. I'm from Disability Rights Vermont. Hi, excuse me. Hi, Diane Bugsy with the Vermont Family Network, and I'm here at the legislature for Mental Health Advocacy Day and listening in on various testimony.
I'm Lincoln Arsenault, and I'm here from the Moncton Ambassador thing.
I'm Kathy Cannell, a mentor for the MAUSD Moncton MCS School, Central School. I'm his mentor, this is my mentee, Senator Hardy. We're here to meet with her, and she invited us to come to this session, so thank you so much.
Good work. Great. Okay, now.
Thank you. And as you noted, thank you so much for your support in the past for the passage of Act 186, which also included with it 3 pilot planning grants. In addition, I am a member of one of the pilot planning teams, which is the one that was awarded to Champlain Housing Trust in Chittenden County. And so it's exciting to see that work start to take off and hope to complete by October of this year. Vermont State, I'm here today just because we like to advocate for not only his desire, but others' desires within IDD and families for stable, permanent, service-supported housing to meet our children's needs. The State System of Care Plan for the Developmental Services Division estimates there are roughly 2.5% of the Vermont population with adults with intellectual and developmental disabilities. Vermont Care Partners estimates that up to 9% of individuals with IDD are either homeless or at risk of homelessness. There are many adults with developmental disabilities living with their aging parents who are seeking a permanent service-supported housing option for them to call home in a community where they grew up and where the community knows them and meets their needs and when their parents can no longer care for them. For families like mine, there are restless nights and worry, wondering who will care for our children when we are gone, to meet the needs and provide them with a happy and meaningful life, which I think he's had today. I'm sure many of you face similar dilemmas of finding appropriate housing and services for aging parents when the role of caregiving becomes too much. The pandemic has taken a toll on many agencies and systems, and families are bearing the load of providing the caregiving and supports for their children with IDD. And I'm going to just quickly pass some pictures around he would like to share.
Hi, my name is Bennett G. Townley. I am 26 years old on Monday. and I've lived in Williston since coming to America in 2001 from Romania. As an individual with unique abilities, I would like to advocate why peer, permanent, service-supported, affordable housing in Vermont is important to me and my uniquely abled friends. I made friends during my time in the Williston elementary and middle schools, as well as peers from surrounding towns when I attended CVU high school. Many of us participate in Special Olympic events as well. You can take your time, but in the photos being passed around, I can tell you that I still ski every winter's games season with Vermont Adaptive on Sundays with my friends in the photo from 2008. I want to continue to live in the community where my friends and I grew up in, as many people know us and will help us if we need it. Most importantly, I feel safer in Williston than I would in other places in Chittenden County. Alas, my friends and I want to have choices about where we live, who we live with, and how we want to live. We would like to see stable, permanent, inclusive, accessible, service-supported housing in our community so we can live together. We need to see affordable housing soon, since many of us are living with aging parents, including my friends and I, and we can't afford regular housing on our own. None of us can drive currently due to various medical and or behavioral challenges, so we would want to live in a part of our community that is walkable or near public transportation and have amenities and work close by, yet is still safe. I also want to live close to nature, as nature helps me to have quiet walks and they help me to regulate and help me with my anxiety. We ask you to please help fund our housing and service providers so Vermont can offer permanent affordable housing for those with intellectual and developmental disabilities on behalf of my friends and I to live in, since that would make us feel more competent in ourselves. We are now at the age where we want to have a place to call home that is not our folks' place or a group home, and experience the same freedoms other people our age do, but with support and a safety net. Thank you for my time to hear my application.
And since the closing of Brandon over 30 years ago, there's been little money invested by the state in service-supported housing for adults with developmental disabilities. The 1999 Olmstead Act directed states to develop a fiscal plan to include housing for people with developmental disabilities in their state budgets. Yet unfortunately, 25 years later, there are no targets in Vermont. The state of Vermont has failed to meet their obligations under federal Medicaid rules and is currently under 2 corrective action plans to demonstrate that HCBS waiver recipients, like my son Bennett, have true choice, including choices of housing. It's exciting to know that the 3 Act 186 pilot planning grants should be completed by October of this year and ready for development. One thing that will support the sustainability of this type of model is for our family members is that they do have the home and community-based services provided through Medicaid to support them, as well as access to entitlement benefits like Social Security benefits to help fund the rent. I'm here today to ask for legislative support to help fund the Act 186 pilot planning grant projects and make them a reality. In addition, we are interested in the establishment of a set-aside percentage units. I don't know exactly what legislatures would like to see, but to create a pipeline of funding to develop service-supported housing for my son and other adults with intellectual and developmental disabilities. To close the gap on the 602 units needed immediately as outlined in last year's Vermont Developmental Disability Council Housing Brief. But even more important is that my adult son Bennett and others in this vulnerable population are provided choices in where, with who, and how they want to live, just like each of us in this room have had the opportunity to decide once we reached adulthood. I believe Vermont can do better, and it will require a collaborative effort between housing partners and service providers to secure and provide the peer service-supported housing of Vermont adults with intellectual and developmental disabilities. Thank you.
Good job, Mom.
You did great.
Good job, Bennett. Thank you. And you know what, I wish we had some more time, but we have one more person who wants to speak with us. So thank you so much for the time you've taken, and we are
And
Actually, we're very pleased that Act 186 has been helpful.
Yep, any questions or comments?
They have somebody else.
Oh, yeah.
I think we're good, and that, but we may have a conversation with you after committee's over.
That would be great.
Thank
Could you
you
have a
both
picture
so
maybe
much.
with some of you?
Yep.
after
Yeah, that'd be
committee's over?
super, love to
I'm
do
just
it.
passing those around. That has our draft ask included in it. And again, it could be subject to change because we're still working on what those fit in and whatnot. Thank you for your time.
Thank you.
Thank you.
Who's next?
Catherine.
Nice job.
Kristen.
Yeah, Bennett, you're a good public speaker. Nice job. Yeah,
Which
really.
does.
Very, very good.
Kristen? Were you gonna?
You're fine.
Yeah.
Don't worry. You're fine. Yeah, it's all good. Yeah.
We're running short on time, but this is important to us. We'll just take a couple minutes over.
Is this your bag? That's not. You got it? Take your mom's bag. Thank you.
Thank you. We'll see you outside. Thank you.
You bet. Good morning. I'm Kristen Chandler from Team 2. I'm the coordinator of Team 2. I've spoken with you in the past,
Yes, you have.
so I'm not going to run through that, but I am here on part of Mental Health Advocacy Day, but also specifically to S-189. I listened when you first introduced that bill about the protocols for DMH.
Oh, so, yeah, let's do this. I'd like to set you up for some time to provide testimony on
Okay.
this 189.
Okay.
Because we're at the end of the day. I thought we were gonna talk about Advocacy Day a little bit, but.
Hey, I can talk about whatever you want.
You can talk about
I did
I
bring
know,
you-
I know,
I brought you some of
you're
gifts.
capable.
Hot off the press is our Team 2 training news, which features, right on the sort of cover story is about an EMS provider who came to the training and learned some stuff and then put it into action in the field right away.
Wow.
So that's for you. So I'm gonna cede my time to Lindsay. How's that?
Sounds good.
All right.
Very nice of you.
We've got
You
about
bet.
2 minutes. That's great. Thank you.
Good morning.
Good morning.
I was here, I had the opportunity to speak with this committee very, very briefly last week. So I'm Lindsay Owen, I'm the Executive Director at Disability Rights Vermont. I'm here to talk about Mental Health Advocacy Day. I will submit my testimony, my written testimony after this so that you can see it because I know we're short on time. So in addition to being the protection and advocacy agency for the state of Vermont, we're also designated by the governor to be the mental health care ombudsman. Which means that we get from the Department of Mental Health, critical incident reports involving death or serious bodily injury of individuals receiving services from the Department of Mental Health, as well as certificates of need, and those are related to emergency involuntary procedures. I've been with Disability Rights Vermont for 11 years. Throughout that entire time, we've received unredacted critical incident reports, which allows us to kind of see what's happening, why people are passing away in the community. 9 months ago, those reports stopped coming, and then they started coming to us redacted, which really hamstrings our ability to see what's going on, and sometimes to even ascertain like what's actually happened, and to see whether or not any follow-up is warranted. I've had conversations with the Department of Mental Health, and I've to no avail. And so just last year in federal fiscal year 2023, I received 73 death reports from the Department of Mental Health. That's a person every 5 days. And again, in most of these cases, there was no planned follow-up identified on these critical incident reports. And these individuals were ranging from 20 to 88, I think was the age range. Many of them say natural causes, even though the death may actually have been unknown, or they were 39 and died in the middle of the day. Sorry, I know we're short on time, so I'm trying to like skip around to what makes sense. So the theme of this year's Mental Health Advocacy Day is welcoming and caring communities and belonging for all. I think DRVT would ask that this committee and others continue to strive to include people with disabilities and other stakeholders in conversations and policy development, and to hold our Agency of Human Services accountable, accessible, and transparent. Let's strive to make sure that belonging for all isn't just a theme for a day, but an honest goal for every day. I appreciate this opportunity to speak with you, and I'm happy to come back and speak on anything related to the work that Disability Rights Vermont does. We are putting together an annual report related to our role as the Mental Health Ombudsman, and I would gladly share that with this committee. Thank you for your time.
Thank you, and please do get your testimony into us, and we'll use that as we go forward. There's a lot there.
Okay,
You know,
great.
and I know how hard you've been working on this. Thank you.
Thank you very much.
Thank you. Thanks. This has been a big day, but a helpful day and, important, for folks who have come into the People's House. We appreciate that. So this is a wrap, so we're gonna go off live